Hello, everyone. I am Andrew Pucker, and I'm happy to be here with another episode of the Clinical Podcast series through the AAOF. I am the Executive Director of Clinical Medical Sciences at Lexitas Pharma Services, and today I'm here with Lisa Ostrin, who is a world's expert in myopia management, and we'll be discussing a poster which is actually at Academy. So we're live at Academy for this episode, which is titled Low-Dose Atropine Influences Static and Dynamic Pupil Metrics in a Dose-Dependent Manner. So Lisa, thanks for being here. Maybe you could just introduce yourself a little to the audience.
Sure, and thanks for having me. I am an associate professor at the University of Houston College of Optometry. I'm a clinician researcher, and my lab focuses on the etiology and developing treatment options for myopia.
So Lisa's clearly quite smart. So you have this poster here at the meeting. Maybe just give us a general overview of the topic and why it's important to optometrists.
Sure. Well, we're interested in the ocular side effects of atropine and looking at side effects that will also give us a little clue into potential mechanisms of where in the eye atropine may be targeting to control myopia. And we're specifically focusing on low-dose atropine that's used in clinical practice, so ranging from 0.01 up to 0.1% atropine. And in the literature, there really isn't a systematic and comprehensive investigation of the side effects of all of those different doses. So our goal was to design a study that systematically evaluated the ocular effects on pupil and accommodation, as well as choroid and interretinal vasculature, to understand where in the eye atropine may be working.
So we know that there are three major treatments for myopia management in the United States that we use. Of course, there's others in the world, such as spectacles, but atropine is one of the main ones. And there's different concentrations, which we often get from compounding pharmacies. But Lisa's trying to better understand the different concentrations. You know, in clinic, we may be using 0.01, 0.02, 0.05, but you're kind of looking at the gamut. So kind of what was your study? Like, who was in it, and what kind of testing did you do?
So we enrolled young adults at the University of Houston Optometry School and looked at compounded doses of atropine from 0.01, 0.025, 0.05, and 0.1%, as well as a placebo. So each of our participants came in for 5 different sessions. Those dosages were randomized, and both the participant and our investigator were blinded to which dose and concentration our participants were getting that day. And they got 1 drop of that particular dose for that day. And before that, we took baseline measurements looking at static and dynamic pupil size under different light levels from scotopic, mesopic, and photopic, as well as looking at static and dynamic accommodation and ocular blood flow parameters. So here at Academy, we're just presenting the pupil data, and we're still undergoing analysis for accommodation and blood flow.
So there's static and dynamic pupil measurements, and kind of just elaborate on that. Like, what's the difference? Why would we care?
Sure. So we are using the Topical Maya instrument, which is specifically designed for following myopia control. And it has an inbuilt feature to test both static and dynamic pupil size. So with a static pupil diameter, we have our participant in a constant room lighting or bright lights induced from the instrument, and simply looking into the camera and measuring their pupil size. And with dynamic measurements, the instrument shines a photopic, so a rather bright light, onto the eye, and the camera dynamically tracks over time how does the pupil constrict and how does it redilate when the light goes off. And then we fit those functions, those traces, with a function that tells us the velocity of pupil constriction and pupil redilation.
Cool. So you did these measurements. What did you find with the different drops of atropine?
So we did our measurements 1 hour and 24 hours post atropine installation. And doing those same static pupil measurements in dynamic, we found that static pupil size was affected for all doses of atropine at 1 hour, and at 24 hours for the higher doses, 0.025, 0.05, and higher, there was still some residual pupil dilation under all 3 lighting conditions: the darkest scotopic conditions, mesopic, and the brighter photopic conditions. And similarly, we found changes in the dynamics of pupil constriction. So there was a slowing of pupil constriction with the higher doses of atropine.
Cool. So thinking about the data as a whole, how could your average clinician kind of use this in practice if they're doing myopia management?
So I think we need to be very clear with our patients what potential side effects they may experience with atropine. And the 0.01% is very attractive because the thought is it has very few side effects. And as we know from the research, from the literature, that the slowing of myopia with the lowest concentration is also conflicting across studies. But what we have found is that even with that lowest dose, there are effects on the pupil as well as accommodation. So our patients just need to be informed that their children may experience some side effects in terms of having a larger pupil. They may experience more photophobia, and they lose also some of their depth of focus. So there may be some effects on vision. And in fact, we also administered a questionnaire on photophobia and near work to our participants. And it was very telling because remembering that they are completely blinded to the dosage, we found that absolutely 0% of our participants noticed any photophobia or near work issues with placebo. But then going into the 0.01%, the lowest dose, we started to get some indication already that participants were noticing some photophobia and trouble reading. So there can definitely be some side effects.
I think you can maybe argue that if there's absolutely no side effects at all, maybe it's just not enough atropine, right? Like I think you need something to get you going.
So in fact, it was very comforting to see this very clear dose response effect in pupil size and accommodation with these dosages. All of our dosages were compounded by the same pharmacy, but after collecting data for 6 or maybe it was 9 months on all these participants and having no idea what the data looked like, and then compiling them and seeing a beautiful dose response curve, we knew that the atropine was getting into the eye and was having this dose response effect.
Lisa, I'd like to thank you for being here today.
Thank you for having me.
Thank you. And I'd like to thank you all for tuning into this episode of the Clinical Podcast Series. I'd just like to ask you to do a few things. 1, like, 2, subscribe, and then 3, tell 10 friends about this. We want to get the word out. So thank you, and I hope to see you on another episode soon.